Welcome to The Scope with Dr. K. I'm Dr. Kosinski. We're going to open the show today, as we always do, by stating that the goal of this show is to present you with a broad scope of value-based care issues, mainly involving the field of gastroenterology, but also outside of GI as well. We're staying in the provider space today. Our guest is Dr. Amar Naik, a private practice gastroenterologist in suburban Chicago who specializes in inflammatory bowel disease. I recently had the opportunity to speak with Amar at the Crohn's Colitis Congress, and after that conversation, I thought he would be a great guest on the show based on his holistic approach to IBD care. Dr. Naik strongly believes in the need for high-quality digestive health care. He feels this begins with a timely confirmation and personalized treatment of the problem and continues by maximizing long-term health and wellness. He believes that preventative care and routine monitoring of chronic conditions help maintain health and avoid emergency hospital care. Combining this healing of disease and feeling of wellness should lead to drastically improved quality of life. To quote him, most patients simply need more than just medication to feel better. They need an emphasis on holistic care. I certainly agree with that. Although Dr. Naik has spent his entire career in an academic medical center, he has recently left to pursue private practice. So we're going to have to talk to him and ask him questions to compare and contrast the care of IBD in these two practice settings. Like me, he spent time at the American Gastroenterological Association. We'll talk about that. And like me, he's a Chicagoan native and lives and dies with Chicago sports teams. He might find time to get into this as well. Welcome to the show, Amar.
Thanks, Larry. Thanks for having me and providing an avenue to talk about some great topics today.
Yeah, well, we're gonna pick your brain. So let's begin. So as my listeners all know, I typically start the interview with a guest by asking them to tell the listeners about themselves. I used to go through long descriptions, but I think it's better when they hear it directly from you. Amar, how did you get to where you are today?
Well, thanks, Larry, and once again, thanks for having me on here. And this is fantastic what you're doing. And well, I guess the easy way to say this, I walking one step at a time with my eyes open, and moving very carefully through the abyss. But frankly, you're hit the nail on the head. I'm a lifelong Midwesterner. Went to University of Illinois and then stayed in the Midwest, got my training and spent a decade plus in inflammatory bowel disease and into this explosion of wonderful advanced therapies. I guess we can't even call them biologics anymore. A lot of novel ways to treat our patients and get them better. And early on in medical school, I just got kind of turned on to the area of digestive health and the concept of being able to talk to patients and see them in the clinic, what I pictured a physician would be, and then even actually realizing in medical school that there were ways to actually do things with your hands and take care of people and diagnose. And the combination of both of those, acuity and emergency, but still being able to build on, that personal relationship with that patient. That's the most fun I have today. Getting in front of the patient and building that bond and taking care of them. So I had a wonderful field. I think we were in the best field, and very biased to say that. And we basically, are at an explosion of looking at the immune system and all the issues that potentially surround them, and really have an area to make a big difference. And initially, going into the academic world was what we knew. All of us, you and I both were at academic institutions for our training, great role models that taught us about how to think. And so you kind of gravitated towards that arena initially and taking care of patients and doing research.
So you knew you wanted to be in GI from the beginning. It's not as though you decided later. You felt this calling early.
I tell you what happened. So I was on and it's ironic that we interact with colorectal surgeons so much, but I was going into colorectal surgery rotation. I thought I wanted to be one of those guys, and to the point where I was practicing throwing my sutures and stitches in and all that. And then I realized I was more interested in the before and after rather than like the operating room. And then I realized that I was close, but then kind of honed in right in GI at that point.
I see. I see. Well, I've always said to people some of the same things you just said. Our patients typically, they don't die. They have chronic conditions. We see them, we build relationships with them over time. And it really lends itself to someone who wants to build relationships with patients. Let me ask you this. The GI tract has so many organs. That's the other thing that makes this such a fascinating field: the esophagus, the stomach, small intestine, large intestine, liver, gallbladder, pancreas, my God. And they each have their own sets of illnesses. How did you wind up focusing on IBD? So many of our colleagues spend most of their time just living in colons with colonoscopies. What made you do IBD?
Well, it was fascinating. The thing about IBD that I think is wonderful is one, I mean, especially with Crohn's and ulcerative colitis, they can affect arguably any part, many parts of the digestive tract. Certainly there's a focus in the small and large intestine. But the fascinating part is there's even stuff outside the intestines, the extraintestinal manifestations, the putting your thinking cap on, trying to kind of have an episode of House MD. I guess there was, one of those episodes where you had to figure out and kind of get some clues and go into it. And so I like that aspect of that kind of the inflammation and, looking at, the advent of genetics and microbiome and a lot of the other fascinating aspects. I saw it actually really as the next frontier, the next step of where GI, wet tract wellness and inflammation and health would actually move towards. And we were just kind of getting into the understanding of immunology and infections, inflammation, and proper functioning of the immune system. And so I found that very fascinating. And I'll tell you that the other aspect of this that really got me early on was looking at who this affected. This affected people in their 20s, in their 30s. And so I thought, hey, if we can make a difference for these people, we can change their lives and help them live a fulfilling life, long, healthy life, and build that relationship. That's one of the big things where I saw a lot of the suffering here.
Well, you're so right on that. I think the median age is somewhere around 40, but that means half the people are under that.
Yeah.
And so it does affect young people. So you pursued this from an academic point of view, and you mentioned this earlier. And I assume that when you started there, you were going to continue there forever, but you've decided to make a change. You've decided to move into private practice. I spent most of my career in private practice. So what made you make this transition?
Yes, it was something about, it wasn't even, to me, it wasn't necessarily about leaving that place for myriad of reasons. It was more about going somewhere and doing something a little different. And so what I've seen it was more about the journey of going there rather than leaving there. But to me, that's how I tried to look at it. And what I saw over the better part of the decades, was a lot of places in academics where we could intervene on patients after they had, failed therapies and done and gotten stuck inside big hospital systems and even had a little bit of difficulty, navigating complexities. And I kept thinking to myself, gosh, if we could have been there a little earlier, could have gotten there a little earlier and gotten ahead of things and monitored things the right way, we could really make a huge impact, right? And so I figured, at two goals, really taking care of IBD patients, and really only two goals. I like to keep it simple: is make sure their patient's life is as long as possible and not shortened by the condition. And then two, making sure their health-related quality of life is as good as it can be, right? For something with a chronic health condition. And so I thought, hey, we need to get out there and get early on, early intervention and get people out there. So I think we need to have that kind of community standpoint in people's communities and out there quickly. And I think we do the same high quality work that the academics do.
Well, hopefully you'll be taking care of patients at an earlier course of the deterioration of their disease than you would at the academic institution. Let's focus on this from the patient's view now. I would imagine that as you build your private practice, it's still going to be IBD focused. And so I think my question is, what's the value of a patient going to a gastroenterologist that focuses on IBD in the private practice setting as opposed to going to one in an academic institution? Is there a benefit from you mentioned what it is from your side. What do you think it's going to be from the patient side?
Well, I think from the patient sides, there are a couple important benefits. One, I think it's a much easier thing to navigate, and getting into the community out there quickly, and having that same comfort, that you'd expect by going to your practice right around the corner, right near where it's very access. So in Chicago, not having to run all the way downtown through an hour of traffic, right? Or navigating things. And then second thing is being able to have access and quick access to patients. Many times in the big academic zones and other areas, it's very, very difficult to get access to your treatment team, to your physician team, your care coordinator, your advanced practice provider. It's very difficult to get access to the doctor. So I think we're able to get there quickly. And I think in terms of being in that practice and someone with a focus in IBD, at this point, it takes a lot of knowledge gaining, and the field is moving at lightning speed, and then in a lot of advanced therapies and the research aspect of it. So being able to really kind of have someone focused and lined up, and someone having that experience of seeing many patients with similar concerns and conditions, I think it can lead to a lot of increased ability. You want to go always see someone that's very useful and very, very known to actually, having that experience. So,
well, Amar, you bring up a good point. The knowledge base of IBD has just been moving at light speed for the last few years. And going to the meetings, I mentioned in the intro that I saw you at the Crohn's Colitis Congress. There are not that many gastroenterologists at these conferences. AIBD and CCC, you wind up seeing the same folks at both conferences. And it's a relatively small community of gastroenterologists who have a focus on IBD. Again, looking at this from the patient's point of view, how do they know that the doctor they're going to actually attends these meetings, actually maintains a high level of knowledge, stays current with everything? From a patient's point of view, how do they know?
Many times they don't. But I think patients should ask, much like like the gastroenterologists who do colon cancer screening. We need to advocate for patients to be like, what's your adenoma detection rate? What are some other quality metrics? What have you seen? What have you read? Tell me what's coming on. And I think there needs to be a lot more development, a lot of outreach in a practice, that suggests that, hey, we are aligned with the Crohn's and Colitis Foundation, who does a great job running the Congress. We are aligned with other comprehensive care networks. We have a way to take care of you in between your patient visits and during your patient visits, and keep you out of the hospital, out of the emergency rooms. So I think it's important to be like, hey, what other resources, what other things does your practice or do you do to help potentially, take care of the patients beyond sending the prescription in or ordering the colonoscopy or the CT scan? Like, what are the strategies we have? And so I think it's very important. I think patients and practitioners, so aligning those two pieces up, have to be kind of aligned and know people that are genuinely interested, because that interest, it's challenge. It's hard work, and it requires. I learned very early on that it requires a team. When I was at my in academic institutions, we had a team of probably 10 that would all work together, and because of that, we had new age math where 1 + 2 = 5, and so we were able to show that the sum of each of the parts was greater than each of the parts by itself. And so I think we really need to expand that. I think we can do this in practice and have all the things that make, that big bad machine out of it, but still have really efficient teamwork concepts where everyone comes aligned to take great care of patients. Because I think great care can mean cost-efficient care, can mean cost-effective care, can mean high quality. All of those things come together, and I think it can really, really easily be done if we just kind of all collaborate together and get out there and and work at this?
Well, you know, at this point, there is no special certification for IBD. That may come. There may come a day where there's a special board certification, you know, for IBD, much like what's happened with hepatology.
Yeah.
And, you know, that is possible. I'm going to break here for a second. If you just tuned in, you're listening to The Scope with Dr. K. Our guest today is Dr. Amar Naik, a gastroenterologist in private practice focused on IBD. So, something you alluded to in my last question had to do with research. And so you've been involved in research in your previous role at Loyola. Do you tend to continue participating in studies in private practice?
Absolutely. I think there has been this kind of motif or that, hey, you're in practice, you're not going to be an academician. And us as physicians, we learn and read every day, all the time, and staying up on things. And I think you can absolutely do lots of great work. You know, my mentor taught me, you know, when I'm seeing patients to kind of have that sense of mind of like, okay, this is your lab, this is your building, this is your area where you can just observe and keep that mind open and attuned and notice and recognize patterns and potentially do a lot of great hypothesis generating work with looking at databases, getting people together, building registries, networks, demonstrating safety of therapies, efficacy of cancer prevention in colon cancer prevention, even in inflammatory bowel disease, showing high quality care, showing how patients are not coming in, things that actually the patients care about, the payers will care about, the docs care about. You want a happy patient. And so there's also lots of great opportunity for clinical trials and lots of programs out there where you'll get the support and be able to move on it quickly. I'll tell you, it's arguably, if you have the interest, there are parts of it that are even easier to do research, where you don't have to have 20 people sign off on the disclosure agreement for the clinical trial to get in and to get at that phase 3 therapy or that new exciting combination advanced therapy to patients early and in the appropriate one, and lots of great things out there. So I think we can still be a clinician educator. There are lots of ways to get out there. I think you're a prime example of that, of teaching and looking at all your experience and evidence, learning that together. And there are ways to do research and take great care of patients right in their community up front. And I think we need more. It's not just the academic centers. There's only a handful. Even Chicago has 6 of them, 6 academic level centers, arguably, but we still have such a big wait time of patients getting in, patients being able to navigate complexities. And so that's been the most eye-opening thing when we joined out there, is like, wow, patients are waiting. They're waiting in an area that's saturated with academic medical centers, and there's still difficulty in terms of getting patients in. Can you imagine in places who only have 1 or 2? And where the focus isn't necessarily at seeing patients with efficiency and effectiveness. So I think all of these things can be done efficiently together. And it really, as we combine and build these networks, we're going to do some great things, I think.
Well, I certainly hope so. You know, one of the other advantages has to do with bringing patients into clinical trials that are community-based, that don't represent the severest of the severe and represent more of the mass of patients that have the condition. I'm certain those pharmaceutical companies would have to be much more interested in having access to those patient populations.
Absolutely. I mean, this is such a hot button topic. I feel like there's a publication on this like once a month on barriers to clinical trials. And people are like, well, what are the barriers? Is it location wise? Is it disease duration? Is it the type of phenotype? Where you look at every single trial, out there, it's kind of interesting. Everybody has 8 to 10 years of disease duration. Everybody has the same kind of breakdown of therapies fail. And it's like this, they're similar enough where you're like, wow, what if we were able to get out there early and evaluate things? There was a trial presented European Crohn's and colitis, I would say ECHO, just in Sweden, where they showed, certain patients, it was a biomarker study, but they showed certain patients' efficacy of advanced therapies and those prognostic-based care. I think we're going to make a good headway there with some of patients, So I think that we gotta be able to branch out and get those patients early on, and we'll have better outcomes in that sense. And having that most take advantage of our heterogeneous patient population in the United States, because trials done here are trials unlike, in these European countries where we're just studying one group of patients. I think we're going to learn so much more in special populations, the Asian population, African American population. It's going to be fantastic, male, female, et cetera. So I think we can do a lot of great work in getting out there, and I think patients can arguably and feel more comfortable seeing that these clinical trials are being run in their offices that they're used to being getting care, and I think we need to just be out in that community and do a lot of outreach there.
Well, Amar, there's definitely an opportunity for you in practice. One of the biggest problems in patients getting access to trials is they may be seeing a gastroenterologist who doesn't have a focus on IBD, is not even aware that the trials are there. And maybe then they get referred to a university program, an academic medical center, and then they get linked in. But there's a delay. There's a time issue there. Your challenge in practice in setting yourself up now is going to be to make sure everybody knows that you're focused on IBD. You're out here. You're an alternative to the academic centers, and the patients can still get the same level of care and can have the same access to clinical trials and cutting edge therapeutics, even close to home, which most patients would love to be able to do that.
Oh, absolutely. I think there's so many great ways that we can do this, and we can pivot and be quick and adjust, as needed, leverage telehealth, leverage things where we can actually get tied in, get plugged in with organizations like the AGA and get support from those in leadership in that area, where we can really kind of get out there and demonstrate quality, efficacy, and prove that, hey, we can do a better job and work together. I think anytime that there's more action in this area, I think it just improves the knowledge base of where we're at. But you're right. Just the awareness, knowing that their option is there, is a huge, huge thing. That, hey, this is something new. This is a way to think about things. Still high quality work right outside in practice, outside of the hospital, where, I think patients, can really kind of get the benefit of great.
Absolutely. These aren't Crohn's patients or ulcerative colitis patients. These are human beings who just happen to have Crohn's or ulcerative colitis. And boy, if we can make their life easier, so they're not schlepping themselves all the way downtown, that make a big difference for them. So you mentioned AGA, and that brings me to my next question for you. I know you've participated. I think you were on the committee that reviews abstracts for DDW, and I know you've participated. I currently am on the governing board of the AGA. These societies are struggling to maintain their memberships. What do you think they need to do? Let's talk about the value. So how do they bring more value to you? What do they need to do?
They do bring, first of all, they bring tremendous value. I think they bring tremendous value to me and to a decent amount of people. But I think we could have a better job of reaching out to unique practitioners, providers, where they're younger in their practice and they're aligned up with experienced gastroenterologists in variety of practice settings. And I think there's a way they bring tons of value in terms of resources, in terms of, on-demand educational programs. I think that can be kind of developed. I think, if there are people that are interested in certain aspects of practice building, certain aspects of specialized care, whether it be IBD or other areas, linking them up with people in the situation can make it really beneficial. I think also talking about how they've helped other people can definitely open up some light in how what other people can see value in some of these kind of relationships that you build. I mean, through DDW, through AGA, we've met just countless number of other practitioners and other people where, just wonderful ideas have come generated from it and have impacted things quickly. So
the network is important. My last question has to do with Sonar. Your group signed on with Sonar. I know you're still in early stages with it, but what do you see as the value of this? Why would you be interested in signing up? Other than it's me.
Well, yeah. Other than the fact that I get to work with you, I think, which is one A, right? But no, and truly, it's been amazing and fantastic. And I'll tell you, we wanted to do this. Actually, we wanted to do this when we were in academia, and there were barriers.
Yep.
There were barriers to do something amazing, something great, something where you had full autonomy, and it was going to be a transformative partnership. And it kind of stuck with me. And now I'm able to do it. And why it's important is I think it's a way that patients are going to have that kind of touch point, that kind of interaction with them, where they're going to feel taken care of in their entire day, every week, every time we need to, right? And it's going to have a nice enough pathway to kind of leverage care together. And it keeps the independence of the practices going together. And it actually also, it shrinks that knowing doing gap. Like, hey, I know I need to monitor these patients. I know I need to keep an eye on them, but how do I do that? You do that with help, and you do that with a team. And so I like to think it shrinks that knowing doing gap and lets you kind of build it. I've already seen benefits from it. And it's like, oh, I was in academics for 10 years. Why do I need help in this, that? No, you need help. We all need help. I think that's the biggest thing what you realize in medicine is know when you don't, know when you know you can use some help and use a hand to do things better. And it's been fantastic. And I think the value in it is patients understand and see that dedication from your practice to do something extra for them. That's not gonna, it's like, what's the catch, right? And there isn't, other than the fact that you're going to be able to take care of them, in between their visits.
Well, I'm going to steal that knowing doing gap. I love that line. I think that really says a lot, because it's not enough to just know. You have to implement, and hopefully Sonar will help you implement. Amar, thank you so much for being on the show. This was great. It was just what I wanted. Thanks to the audience for tuning in. You can access our podcasts on most all of the podcast platforms like Apple Podcasts, Google, Spotify, and others. Learn more about the show on the programs page at healthcarenowradio.com, and lend your voice to the conversation on Twitter at HCNowRadio. Be sure to follow us on Twitter at SonarMD. We're bringing patients, providers, and payers together to reimagine GI care. Until next time, I'm Dr. K. Stay well.